A very good afternoon, Associate Prof. Dr. Khaldun Ismail, Dr. Nick Azlan, our panelists, Prof. Dr. Vinay Wananukul, Dr. In Sung Hak, and Dr. Anissa Adnan, and to all the doctors and the final year medical students in attendance. My name is Vera, and along with my friend Leong, final year medical students currently in emergency medicine posting, we will be emceeing and moderating for today's webinar.
Welcome to the fourth series of the Clinical Toxinology webinar, organized by the Department of Emergency Medicine, University Kebangsaan Malaysia Medical Center, UKMMC, in collaboration with Remote Envenomation Consultancy Services, Malaysian Society on Toxinology, Clinical Toxinology SIG, College of Emergency Physician, National Poison Center Malaysia, and Malaysian Biodiversity Information System. In this webinar and forum, we aim to explore the topic of clinical toxinology. Is it relevant to medical students? Just some housekeeping rules before we begin. Do use our Zoom background provided. Feel free to ask questions through the Zoom Q&A. Feel free to have any questions, and the questions will be addressed at the end of every cases. And there'll be a feedback form at the end of the webinar to receive your certificate of participation.
To deliver our opening remark, please join me in welcoming Associate Prof. Dr. Ahmad Khaldun Ismail. He is a consultant emergency physician, the founding consultant of Remote Envenomation Consultancy Services, REX Asian, and founding director of the Asian Marine Animals and Snake Envenoming Management Symposium. He is a member of the WHO Global Roster of Experts and Technical Advisory Group on the Prevention and Control of Snakebite Envenoming. He is currently an honorary scholar at Graduate School of Medicine, Tohoku University, Sendai, Japan, honorary consultant at the National Poison Center, University Science Malaysia, and a resource person at the Malaysian Biodiversity Information System, MYBIS, Ministry of Energy and Natural Resources. He was the president of Malaysian Society, MST, on Toxinology and a review advisor for the WHO Snakebite Envenoming Working Group from 2018 to 2019. His special interests are in clinical toxinology, emergency medicine, and pre-hospital care. He founded various educational programs related to clinical toxinology for the public and healthcare professionals. He is passionate about teaching and frequently invited as a speaker in Malaysia and internationally. He holds the authorship of several academic publications in related areas of interest. He enjoys traveling, nature, swimming, and good coffee. Without further ado, Prof, the mic is yours.
Thank you, Vera. Thank you for the kind introduction. Welcome, everybody. Would like to congratulate all of you were able to make it to our last webinar for this series in 2023. Clinical toxinology, is it relevant for medical students? So this is our fourth and final episode of the webinar. And we will have actually very prominent expert panelists that will be joining us this afternoon to discuss on the cases that will be presented later. So I will not be doing the introduction to the panelists. Our moderators will take over the running of this program. So I would like to take this opportunity to also congratulate all our secretariat who has been working tirelessly over the past almost 2 months to get things done. And I hope all of you will enjoy today's session. With that, I thank you.
Thank you, Associate Prof. Dr. Ahmad Khaldun Ismail.
Ladies and gentlemen, joining us today, we are very grateful to have the panel of experts. First, let me introduce you to Prof. Vinay Wananukul, a professor of medicine. He is the director of Rama Tibodi Poison Center and head of Department of Medicine, Faculty of Medicine, Rama Tibodi Hospital, Mahidol University. Prof. Wananukul graduated from Faculty of Medicine, Rama Tibodi Hospital in 1984. He received his residency training at the same institute and earned the Thai Board of Internal Medicine in 1990. He joined the Division of Clinical Pharmacology and Toxicology, Department of Medicine, Faculty of Medicine, Rama Tibodi Hospital after the training. He received fellowship training in clinical pharmacology and toxicology at Hennepin County Medical Center in Minneapolis, USA in 1993 to 1995. Prof. Wananukul was a president of Asia Pacific Association of Medical Toxicology in 2008 to 2010, and president of Thai Society of Clinical Toxicology in 2009 to 2014. In 2016, he earned a fellow of the American College of Medical Toxicology. His works include natural toxins poisoning, heavy metal poisoning, management of antidote supply, and poison center. We would also like to grab this golden opportunity to congratulate Prof. Wananukul for his recent publication titled A Retrospective Cohort Study of Cobra Envenomation, Critical Characteristics, Treatments, and Outcomes.
Next up, please join me in welcoming Dr. In Soon Hak from Cambodia. Dr. In Soon Hak is the Medical Director of Kemasen 2004 International Polyclinic, Intensive Care Unit Specialist, as well as a member of Cambodian Society of Anesthesiology, Critical Care and Emergency Medicine, and a member of Rex Asian. He graduated from University of Rouen, France 2020, University of Health Science, Phnom Penh, Cambodia 2019, Program for Emergency Dialysis in Japan in 2019, and Cancer Pain Intervention Siriraj Pain Management Clinical Training Center, Bangkok, Thailand.
Finally, please join me in welcoming Dr. Anissa Adnan. She's a medical toxicologist, currently serving as a consultant of emergency and trauma physician at Emergency and Trauma Department, Hospital Malacca. She graduated with a degree in Bachelor of Medicine and Surgery, MBBS in UM in 1999, followed by Masters of Emergency Medicine in USM in 2007. Subsequently, she graduated with Emergency Ultrasound Echo in National University of Singapore in 2006, International Toxicology Fellowship in UNM School of Medicine, and New Mexico Poison and Drug Information Center in 2006, as well as Southeast Asia Regional Counterterrorism in 2008. A warm welcome, Prof. and doctors. Thank you for joining us today.
Next up, we will provide a brief introduction to our fellow final year undergraduate medical students on the topic today, which is clinical toxinology. So, toxinology and clinical toxinology is a two different things. For toxinology, it is a scientific study of substance produced by any living organisms, either from animals delivering the venom or residing tissues within, mushrooms or bacteria, and all of these substance may harm its target organisms. Meanwhile, for clinical toxinology, it is actually encompasses a broad range of medical conditions covering envenomation by venomous animals, poisoning from ingestion of animal parts, or the plant toxins. What about envenomation and poisoning? So, envenomation is exposure to venom containing toxin resulting from bites or stings from venomous animals. Meanwhile, for poisoning, it is the administration of poison which contain natural toxin into one's body via swallowing, inhalation, or absorption through skin. So in Malaysia, we have various organizations that work regarding toxinology. Firstly, we have Malaysian Society on Toxinology, Remote Envenomation Consultancy Services, REX. We have Clinical Toxinologies, Special Interest Group in College of Emergency Physician. We have Malaysian Biodiversity Information System, MIBIS, and we also have National Poison Center.
So allow me to share a survey that we have discussed with the final year medical students in UKM. In terms of students' perspective, we have asked the students to a question whether they have ever heard of a clinical toxinology. Interestingly enough, 97% of them have never heard of clinical toxinology. And when we asked whether they agree that it is relevant to medical students, 91% of them suggested yes. So moving on, what is the importance of clinical toxinology for medical students? Firstly, it is a common occurrence in Malaysia. Secondly, it is important for emergency care. And if it's untreated, it can be life-threatening. So where would be the best place for us to learn about the importance of clinical toxinology? Based on our study, it is actually during our emergency medicine posting, internal medicine, and family medicine. So I would like to extend a question to Prof. Wananukul. Did you have an experience of learning clinical toxicology during your undergraduate studies?
Good afternoon, everyone. It's my pleasure to join this program. And I would like to thank Professor Kadun to invited me for this conference. And I think that this is, I agree with you that clinical toxicology or clinical toxicology is relevant for the medical student, because after you graduate and you practice in any part of our country, I think that Thailand and Malaysia is the same. Clinical toxicology is still one of the problem among many problems in our country. Thank you.
So, Dr. Ng, I have a question for you as well. Do you feel that it's important to do so, and why? What are the several reasons that you think it's important for medical students to learn about clinical toxicology?
As I said, that the first one, it is a problem, still a problem. And if we can diagnose the patient, we can treat the patient, because some of the toxin may be life-threatening. But if you diagnose it and treat the patient properly on time, you can save the patient's life. I think this is very important.
Thank you, Prof, for the previous answer, and also Dr. Ng. So for the last question, Dr. Anissa, when do you feel is the right time to incorporate clinical toxicology in our curriculum?
I think it can be started with your clinical years. For our local universities, I think the clinical years starts at year 2. So the introduction to clinical toxicology can be introduced slowly, starting from second year onwards, and maybe with more exposure in your 4th and 5th years of med school.
Understood. Thank you very much, Doctor. Sorry, Dr. Ng has disconnected. Dr. Ng, are you back into our group?
Yeah, I'm still here.
Okay. So, Dr. Ng, sorry, can you repeat the answer just now, or do you want me to repeat the question?
Oh, it's okay. It's okay. Anyway, good afternoon to everyone. It's a pleasure to be here with everyone and all the medical students. To me, personally, the term of clinical toxicology was not appear during my medical school, medical life as a medical student. So we only learn about the snake and reanimations, and that's the only thing that we learn. Throughout the experience as an emergency specialist, I believe that the clinical toxicology is quite important for us as an emergency specialist, because as the urbanization is increasing, the urbanizations continue to grow, which means people become closer to the snakes, to the animals that could cause health problem to us, and we as an emergency specialist should be ready at all times to treat our patient. Thank you.
Thank you very much, Prof. Wananuko, Dr. Ng, and Dr. Anissa for your insight.
Okay, so next up, we will have 4 case presentations. After each case, we will invite the panelists for some discussion and followed by short Q&A session. So for the audience, if you have any queries, you can drop it in the chat box during each case presentation. Now let's invite Leong as the presenter for case 1. He will be presenting a case of a 44-year-old male with no known medical illness with an alleged snake bite on the right wrist.
Hello again. So allow me to give some insight to the common snake sightings due to weather changes in Malaysia. As you can see from this slide, there's actually multiple cases reported in Malaysia that has common sightings of snakes. And most of the specialists have concluded that it's due to weather changes in Malaysia being much more hotter than usual. And this is a case report done by Prof. Zul Fahimi. a case of a fatal envenomation by a captive puff adder in Malaysia. So I would like to discuss a case with the prof and doctors here today, where it's a 44-year-old male with no known medical illness, came in with a snake bite at the right wrist area. So at 8 p.m., the patient was bit on the right wrist by a yellowish black colored snake with no evidence of the snake. He could not recall the snake. So he immediately washed his hands with tap water and came to the emergency department at 11 p.m. Patient denied any medical or surgical history with no known food or drug allergy. And upon arrival, there was bilateral ptosis with slurred speech. So on examination, patient's vital signs were as follows during admission, where the BP was hypertensive, 168 per 130 millimeter mercury, 88 beats per minute for our pulse rate, which was normal. SpO2 was good at 99% on room air. He was afebrile at 36 degrees centigrade, and respiratory rate was acceptable at 18 breaths per minute. On examination, patient was alert and conscious, GCS was full. Systemic examination was unremarkable. However, there was noted to have 2 sting marks on the right wrist of the hand with no bleeding measuring 0.5 cm apart. Upon arrival, patient was given 5 vials of neuropolyvalent antivenom. And on the second day, patient's GCS score deteriorated with pupils 5 out of 5 and not reactive with SpO2 further dropping. Thus, patient was intubated with GCS score of E1, VT, and M1. Other than that, patient's vital signs were unstable as follows. BP was hypertensive at 193 per 97 and pulse rate 107 beats per minute. Thus, he was given amlodipine and GOD, and he was also admitted to ICU for further management. Patient was subsequently given IV midazolam to act as a sedation. At the same time, he was also given another 2 cycles of NPAV, which is overall of 10 vials. In terms of physical examination, the extent of hand swelling remained the same with no dermonecrosis. Laboratory investigation noted that the ABG, the impression given was a compensated respiratory acidosis, and full blood count noted the HB was normal, but there was leukocytosis and platelet was normal. Liver function test was normal, and coagulation profile was normal as well. For the renal profile, the urea and creatinine level was raised, and it was given an impression of possible AKI, and creatinine kinase was 338, which was markedly raised. So patients progressed on the 3rd day. The patient's GCS score improved drastically, being able to respond to verbal stimulation with eye opening upon command. This was after given 10 vials of NPAV. Patient was also able to move fingers and toes upon verbal command. However, patient is still intubated, making his GCS score E3VTM6. Pupils were 4 out of 4, responsive but sluggish, gag reflex was present, no wheal noted at the puncture site at that time. So on the subsequent day, the patient's ventilator supply has been reduced with good oxygenation. He is also no longer on any sedation or inotrop with vital signs stable. And on examination, pupils were 3 out of 3 reactive with GCS of E4VTM6. However, patient's cough reflex is still weak with worries from the anesthesiology team regarding his ability to maintain AV. Thus, patient was given neostigmine for motor function. Post-neostigmine administration showed improved in motor function, where he was able to flex ankle and move both hands compared to just clickering fingers previously. And patient's lung function also improved with increased tidal volume. Subsequent days noted further improvement in both motor and lung function, and patient also responded well with strength improvement post-neostigmine administration. So I would like to invite Prof and doctors for your feedback on this case. Thank you.
Thank you so much. It was a very interesting case. Maybe we can have a bit of go back to the first slide to see the case itself, how it happened. Maybe then we can get Prof. Vinay to start the ball rolling to comment about this case. What do you think? Second slide, please. Next slide. Yeah.
Next slide.
Next slide. The case. Yeah.
Yeah. Okay. I think that for this case, it is quite classic for the neurotoxic snake bite because he have ptosis and slurred speech at the time that he arrived to hospital. So for the diagnosis of the snake bite is not quite difficult because the patient already have the sign of toxicity from the venom. The problem is that what kind of snake that bite the patients. In this region, understand that we have two groups. The first group is the cobra and king cobra, and the second group is the banded crate and Malayan crate. And the difference between these two groups is that for the cobra and the king cobras, usually they have what we call the local effect, quite remarkable compared to the Malayan crate or the banded crate. So in generally, if I see this kind of the patients, I will think that and the my differential diagnosis is Malayan crate. Why I don't lead the king cobra in my differential diagnosis? Because usually the king cobra with snake is quite difficult that you found in the communities like this. And for the banded crate, is compared to the Malayan crate, it's less common. So the diagnosis will be the first one is a cobra bite. The differential diagnosis will be the Malayan crate.
Very good, very interesting. What about Dr. Sung Hak? What Dr. Ng? Dr. Sung Hak? What do you think? Do you agree with what Prof. Vinay comments so far about this case?
Yeah, actually, Prof has been very detailed on the diagnosis and differential diagnosis already, and I am totally on the same page with him. For me, related to the experience of this case, it is quite obvious that the patients come in with a bilateral ptosis and slurred speech. So, thinking in the first place, and usually in our center, we had the neuropolyvalence from Red Cross in Thailand available, and usually if the patient's consciousness is deteriorate, it is recommended that we provide it right away in the emergency
Dr.
room.
Anissa, would you like to comment something about the diagnosis, perhaps? Maybe there's a bit more detail. Can we see the next slide, please? Yeah. Dr. Anissa, would you like to have some comment, maybe, about the history and the vitals,
because somebody
maybe?
mentioned about puff adder. So I was wondering how was the species identified as a puff adder?
No. That was the cases before. Some.
Oh,
Yeah. So, but this case is. What do you think about this case? Do you think it's a
well,
right?
where is the geolocation of this patient? I think for us, we look at the region. In the northern states, we might lean towards crates. I think we get more crates up in the north compared to the south. We have never had a crate before in the southern region.
Me too. Okay.
Oh, we have.
Yes, we do.
But other than that, the presentation looks like this is a neurotoxic envenoming.
Okay, good. Right. But what about the? You can see the picture here. What about the beaten area? Do you think it's kind of a pathognomonic of a cobra bite? Dr. Sung Hak, maybe?
To me, I believe it more likely to be a crane bite. I believe it more likely to be a crane bite than a cobra bite. Could be a Malayan crane.
Yeah. Prof, is it typical for cobra bite to don't have what you call dermonecrosis? As you can see this case, the bite area is very small and not really so much local tissue necrosis, no?
So is there any swelling in this picture? I'm not sure.
No, very little.
Very
There's
little.
no.
Okay. So usually, if there's no reaction, no local reaction, Malayan crane is more common than the cobra bite.
Yeah.
However, in Thailand we have some experience that some cobra bite they also have a very little local effect as well. So this is why they have a differentiation between the cobra and crane. But if you see that there is very little, it will be the crane. Malayan crane is more common than cobra.
Yeah, so the one that caught my attention is on this slide also. You can see there's a scar, kind of big scar on the dorsum of the hand. We do not have the history how this scar occur. Maybe he was a snake handler before or get in contact with the snake bite or some sort of injury that he may develop this scar in the past, but we did not explore on that history. But the history that he gave was he was bitten by a yellow and black colored snake that he is very adamant about it, but he did not provide us with any picture of the snake. So that is another issue. But the problem was you can see the onset of symptom is very quick. It's just about 2 hours since incident until he arrived to hospital. He already have ptosis and some difficulty in breathing. And antivenom at that time, because of you can see very little, as Prof said, local tissue damage, therefore, and not so much swelling. So they were thinking on the line of a crate. So that's why NPAV was chosen, because in Malaysia, we do not have the specific antivenom for crate. So we rely on the NPAV, neuropolyvalent antivenom, which contains the both crates also in the NPAV. So that was given, and apparently he developed a very slow recovery. As we can see, he's after day 4, even after giving the second dose of the antivenom, he wasn't fully recovered, which we will normally see a kind of a quick full recovery of neurological function if it was a cobra bite, for example, from our experience. But because it's a crate, so as we know, it can affect different part of the neuromuscular junction receptors, which is also the presynaptic, and causing damage to the neuromuscular junction. So that's where the antivenom may not be working because the damage has already been done. So now he will require, normal regeneration of the nerve endings again to recover. In which case, we did attempt, as you can see. Dr. Anissa, would you like to comment about the giving of new stigmine for this patient? This is a very interesting therapy that is given as adjunct to the antivenom. After given antivenom, you can see he was given new stigmine, and I think you have experience also with new stigmine in managing your case in Malacca. Dr. Anissa? Yeah.
My experience in giving neostigmine was for a
Cobra bite.
Yeah, I recall. Where the patient was given monovalent, the Naja cautia antivenom. He was intubated and he was given the NKAV, but when they tried to attempt to extubate, I think there was some difficulty in terms that his response was not as well as to be expected. So considering whether he would require further antivenom or not, we decided to give a trial of neostigmine, which he responded very well to. And so subsequently he was given further antivenom prior to extubation.
Yeah, so that's I think there's a role for using what we call tensilon test. This is part of the process of using non-antivenom drugs that we use for myasthenia gravis, right? For those having myasthenia gravis. So we check with tensilon test using hydrophonium, but we don't have hydrophonium. So what we have is a neostigmine, slightly longer acting, and also physostigmine. So in this case, our anesthesiologist decided to use neostigmine, and apparently he responded well with that neostigmine. He was able to breathe better, and he was able to open his eyes. A muscle start to have some movement in the distal limbs. So they continue the neostigmine for I think a few days, and subsequently he was tried to be, because his gag is not fully back on, but he was able to cough. But so they decided to have a trial of extubating the patient. So they extubated, but unfortunately the next day he had some difficulty in breathing and having some possible aspiration of saliva or mucus. So they re-intubated him again, and after 2 days, he was, I think a few days, so he was able to regain some more motor function, and finally he was extubated fully. So he was in the hospital for quite some time. This was last month. So this patient was in the hospital for I think almost 3 weeks in the hospital. So I think he's probably still is in the hospital, not fully regaining, and he was put on physiotherapy as well. So he in the meantime, while he was intubated and ventilated, he was given, of course, for replacement food for energy. So all those are already on board. So anyway, yeah, this is a very interesting case to me. Thank you for your input. I think this is a very classic sign of, as Dr. Sung Hak was saying, crate bite, but which crate we are not sure. But according to the patient, is yellow and black, and if we look at that color combination, it's Bungarus fasciatus, which is banded crate. We don't see much. Apparently, Prof. Vinay, in Malaysia, we see more banded crate bite rather than Malayan crate bite. So it's the other way around.
Okay.
It's quite different to Thailand, maybe.
Yeah, this is a different. But if we believe that the history is correct, that this is a yellow and black, it should be banded crate.
Yeah, but that's on retrospective. But the thing is that we don't really have the evidence, right? So we
Yeah.
still treat it as a neurotoxic envenomation, and the antivenom is correct. ABCD emergency intervention is also correct, and luckily he was in the hospital before he gets worse, and was able to be treated according to our protocol. So he, I think, survived this ordeal. So that's a very good message we should put forward to all our junior doctors. Have to be very vigilant in actually managing such cases. We don't know, it's undifferentiated case, but just purely on the symptoms that the patient presented, we can still actually help the patient well by consulting to, of course, some experts. So the diagnosis, I think, in the end is going to be still unidentified snake bite with neurotoxic sign and symptoms of envenomation. In bracket, maybe we can put there probably a Bungarus species. We cannot tell which species this is. Okay, So that's it. Thank you so much. So let's move on to the next case, perhaps. Thank you.
Okay.
Thank you very much to Prof and doctors for your input. Now I'd like to open the floor to any medical students to ask any questions, if there is any. If not, we can move on to the second case. So moving on to the second case. The second case is about hornets. Hornets, where we have found two cases on the newspaper, where there was a swarm of angry hornets killing 3 in Indonesia, where 3 people have been killed by a swarm of angry hornets in Indonesia over the past 2 weeks. A health agency official said on Friday after hundreds of reported attacks in recent years. The latest one was an 11-year-old student died in West Java Wednesday after he and 3 other pupils tried to destroy a nest of lesser-banded hornets, and a species notorious for its aggressive behavior and a sting that can trigger a life-threatening allergic reaction. Another case that we have found was on the newspaper as well, where 8-year-old Dungun girl stung to death by hornets. She was in critical condition during admission to Sultana Nur Zahira Hospital, HSNZ, after suffering 65 hornet stings. She subsequently passed away due to multiple internal organ failures from the toxins released by the hornet stings. So I'd like to open the floor again to Prof and doctors for a discussion about hornet stings. Thank you.
Maybe Prof. Vinay, would you like to start first?
For the hornet, usually we have a hornet, we have a wasp that is quite the same. In generally, this insect can produce toxicity from 2 mechanisms. The first mechanism is from hypersensitivity, that they may cause anaphylactic shock or something that make the patient has a cardiovascular collapse, respiratory failure, and die rapidly if we cannot maintain the airway, we cannot give the adrenaline on time to the patient. And this is not depend on the dose, but this is a hypersensitivity. And for the second mode of poisoning from the hornet is from the toxin itself that in the sting, and this is dose dependent. So the risk of they will develop toxicity, how severe it is, depend on how many sting that the patient received from these animals. And there are some arbitrary number that some textbooks said that more than 20, some textbook mentioned that more than 50 that will have a high risk to develop severe toxicity from the hornet. And the toxicity of this insect, they cause multi-organ failure. But the organ that cause the patient cardiac arrest rapidly is from rhabdomyolysis. Usually it occurs, it might be 10 hours or 12 hours after beaten. The patient develop rhabdomyolysis and hyperkalemia, and they have a cardiac arrest from hyperkalemia. And if the patient survive from this rhabdomyolysis, the patient still have acute kidney injury, renal failure, and also in very severe cases, they also cause liver failure as well. That is the severe case that I ever had in my life. Okay, thank you. For the treatment of the toxicity from the venom, right now we do not have any specific treatment. The treatment is just only supportive care.
Danisa, would you like to have a comment about these two cases? Or Dr. Sunghak?
The the only experience I had encountered with the hornet sting were allergic reaction like anaphylactic shocks. So basically, we proceed to the management of the anaphylactic shocks and keep observing the patient. And the following day, and the patient keep on improving as we deal with the anaphylactic reaction with the steroids and antihistamine and other thing. Honestly, I didn't encounter any specific experience dealing with the hornet sting, as in the case report mentions above. Thank you.
Is Dr. Anissa back? Would you like to give a comment? Dr. Anissa? Yeah. What about our experience in Malaysia? We see this quite often, actually.
Would I unmute? Okay. Yeah, I personally I have not had much experience with severe hornet stings here in my hospital. The most that we get are allergic reactions or anaphylactic reactions, which we treat symptomatically. I have not had any patients that develop rhabdo or acute kidney injury from the hornet stings so far.
Okay, so this is interesting because you mentioned about allergic reaction. So which type of hypersensitivity reaction that you expect from such a sting, Prof. Vinay? Is it does the patient require sensitization prior to developing anaphylaxis, or just from the first sting already causing a problem with reaction?
I think that the hypersensitivity that we have and we found, it's range from very mild, just like something like urticaria that around the sting area, until the most severe case is anaphylactic shock. So and in some patients, they did not have a history that they ever have stung before. The first time this still happened. This is maybe because that the venom that in the sting, they contain many vasoactive amines that includes histamine as well. So
Yes.
sometimes it might be caused by the histamine in the
Yes.
venom instead of it is a real hypersensitivity.
Yeah. So they can actually stimulate sort of like a similar effect to a allergic reaction or anaphylaxis just from the first encounter. It doesn't. But we do hear a lot of patients get so-called allergic to bee sting. So they had stung before by bees, and then it was okay, and then they get stung again the next time. It became a full-blown anaphylaxis. So that could happen as well, right? So is there the difference between bees and hornets? What do you think? Dr. Ng?
I honestly don't have an experience between the bee and hornet, honestly.
Okay.
Just a small information. I had encountered an hornet sting. It was not an allergic reaction, though. It was a complicated sting. After a week, the patient seems to have scratched the sting and then develop a cellulitis. So
Kind of a secondary
rather than
infection, is it?
rather than treating the hornet sting, we treat the
Right.
cellulitis. Thank you.
Okay. Okay, Dr. Anissa, you want to have any more input regarding Hymenoptera stings? This includes fire ants as well.
Yeah, probably with hornets, they can sting multiple times, as I understand.
Yeah.
Yes.
So this child is definitely have a high load of venom, right? 65 sting. It may be 65 sting from the same. The same hornet can sting many times. But if it is a bee sting, it can be definitely 65 different bees, right? So this child may be just stung by 20 hornets, but the number of sting injury that she suffered is more than the number of the hornets that attacked her. Yeah. So so that's very important as well, as why I think this number is mentioned, because important, if the patient who was stung by a hornet or by bee, we need to count the number of sting. We have to identify the area, and I think the most difficult part to look at is on the scalp, because we have to look under the hairs and to also count this area. So we sometimes miss the count on the scalp area, and the scalp is also very rich in blood supply, so that area can get inflamed and may contribute to the severity of the injury. Yeah. So hornet sting in Malaysia is not uncommon. We had several cases almost every year, and there were several deaths as well, as this case already demonstrated. This is quite recent, I think. Most of the time that the death occurred in children. I'm not sure in Thailand, but or elsewhere, but also in Indonesia, as you can see, the first one also involve children, and they do get what you call very bad reaction and also complications. As Prof said, they can cause multiple organ injuries, multiple organ failure. On top of that, rhabdomyolysis causing hyperkalemia that triggered to the heart having arrhythmias and perhaps asystole as well. So how do we manage? As Prof Vinay mentioned, we don't have antivenom for hornet sting or for bee sting. So it's always a case of supporting the patient. We do have a situation where we had to dialyze the patient early. We can actually anticipate. We anticipated the severity of the problems before it happened. So we know the number of sting. We know that the patient has a high venom load, and therefore already pre-planned for dialysis if the acute kidney. We already see there's acute kidney injury, and the patient went into more severe situation that they had to intubate. The rhabdomyolysis, the CK was very high, I think in the thousands. The one that we see here just now, you mentioned, is only I think 600 something, right? Oh no, that was the previous case. But the CK was high, so that's why they go into dialysis as well. And one of few cases that we did do that, and the patient did survive the ordeal. Now, the dialysis is not to neutralize the venom. Some people say treat envenomation using dialysis. We do not do that. Doing the dialysis is to respond to the acute kidney injury that the patient had. Okay, so that's the reason for the dialysis that we do for such patient, not to neutralize the venom. So we do not have the antivenom for hornet sting or bee sting yet. Okay, so what about if somebody had already allergic reaction? How do you manage it, Prof? Or do you have, like in the US, they have this injectable adrenaline to be prescribed to patient? Is that a practice in Thailand as well, or in Myanmar? In Malaysia, we don't have injectable prescription. What do you call that? The EpiPen, right? We do not have that in Malaysia. What about Thailand? Your mic, Prof. Can't hear. Prof, your mic is on. Your mic is not on. Sorry.
Sorry. We did have in the past the EpiPen, but because the volume that we use every year is very small, so the price is very high. It's I think it is about 3,000 baht for per one EpiPen, and the shelf life is just only 1 year that I can recall. So right now we do not have, but our pharmacists have already prepared the EpiPen by ourselves that they use for some patients that very high risk to develop hypersensitivity anaphylactic shock from any cause. They may have the adrenaline pen.
So the patient is prescribed and they can bring home adrenaline with
Yeah,
them all the
they
time?
can in the high risk they can be. So, but
That's
for
very interesting.
for the patient who bitten by the bees or by the hornet, usually we suggest them that they should identify the place that the habitat of this hornet and try to remove it out, that to make sure that they will not bitten again.
Yeah, because there's issue about the misuse of this drug, one thing, and then it's not under medical supervision to be given. But the EpiPen doesn't need medical supervision to be given, right? So if you can actually provide the same kind of amount as per EpiPen and make sure the patient is trained how to use it, then surely that can be given to patient as a prophylaxis, well, not prophylaxis, but as a tool that they can carry with them. What do you think, Dr. Anissa, about this? Because we had some issue also about using this for wilderness medicine. You know, people go out into the wilderness, do some activities, and they want to carry adrenaline jabs with them. What do you think? Is it okay?
I think if you want to carry something like an EpiPen, you should be appropriately trained to use it, especially where to inject it.
Yes. Yeah, and it says it's supposed to be prescribed, right? It's a prescription, right? If I'm not mistaken, in the US, your experience in the US?
I think when I was in the US, it's also difficult to get an EpiPen. But yes, I do
Oh,
agree. It's a prescription and it's
okay.
very expensive.
Yeah. Okay.
I think that it is not for everyone. It's
Yeah,
just
it's not for
patient
everyone.
have a
Yeah.
high risk patient. So the physician have to decide who should have the EpiPen,
Yes, yes.
not just for everyone. So
No, it cannot be over the counter. You cannot buy just over the counter.
and
Yeah.
they need to be instructed.
Yes, some training as well, definitely. Yes. Yeah. Okay. Very interesting discussion. Any questions? Our moderators?
Thank you very much, Prof. and Doctor, for the very thorough explanation about the hornet stings, their anaphylactic reaction, as well as the introduction to EpiPen. So I would like to open the question to the floor for all the medical students and see if they have any question for Prof. and doctors about hornet stings.
You can type the questions in the chat box. We can ask the question later as well. Okay.
So
Okay,
there's
there's
a question
there.
from
Yeah.
there's a question here. So the question from one of the medical students is that, will the number of hornet stings affect the condition of rhabdomyolysis?
Maybe Prof. Vinay?
Yes, it is. In general, we believe that the hornet contain more venom than bees. So usually, in some textbook, if the patient bitten by a hornet more than 20 sting, we will identify that they have a high risk group. It is they are the high risk group that would be develop the severe poisoning from the venom of the hornet. But for the bee, in some textbook, they suggest 50 sting to determine that they might have a severe complication from the venom. And rhabdomyolysis is one of the complications. that we have to looking for in the patient who bitten by multiple sting. Okay.
Okay, that's good. Any more questions? Yeah, we have one more. I think.
Yes, we have one more question from the floor. Is that what can we do at home after getting stung by a hornet before arriving to the hospital?
Okay, maybe Dr. Anissa want to respond to this, or Dr. Sunhak?
Okay, first stay calm. Okay, I would advise you to go straight to the nearest hospital or healthcare facility without wasting time. Do not apply anything. Do not try to rub the bitten, the stung areas. Um, I would not even suggest to waste time applying any local application or icing. Just go to the nearest hospital as soon as possible.
Yeah, but do you even for one sting, do you ask them to go to hospital, or how does it work? Is there a certain caution that of course we ask them not to disturb or temper the stung area. Yeah.
Then yes,
Yeah.
even with one sting, we would recommend you to check into a healthcare facility just to make sure that you do not develop a severe reaction, especially an anaphylactic reaction.
Yeah,
But
especially if you are already sensitized before, right? If you are sensitized before, even one sting can trigger the allergic reaction, right?
right.
Yeah.
But if you're not hypersensitized and you don't have history of A2P and it's not causing too much pain or swelling, then probably the first thing you would want to do is icing and remove the stinger if you can.
Yeah, that's for a bee, right?
Yes. And apply some ice pack and take some painkillers.
Yeah. Okay. Dr. Sunghak, you want to add on a bit? Anything?
I would. Personally, I would recommend to observe the redness after the sting. Like 5 centimeters should be a good number for the observation. So within the first 24 hours, if the redness is more than 5 centimeters, and but from one sting, of course, then the reaction should be, expected to be exaggerate more. Then consulting a physician is a good idea. However, if after the sting and the redness is less than 5 centimeters, it doesn't cause any pain, too much pain. I recommend to just stay at home and observe. But to understand that the distance from your home to the hospital is also short. Otherwise, this would be sometime cause problem. Thank you.
Yeah. Okay. All right. Okay. Moderators, are we okay?
Okay, so we can move on to the next case. So next case is case 3. Okay, so this is a case of a 7-year-old girl weighing 20 kg with no non-medical illness, presented to clinic after alleged ingestion of S2E4 She was brought to clinic after being found collapsed and unconscious at home with prior history of dizziness and vomiting. So upon initial assessment in the clinic, she was unconscious with GCS of 3/15, pupils 3 mm reactive with presence of spontaneous breathing efforts. The vital signs, BP appears hypotensive, 90/55. Heart rate normal, 87, and SpO2 is 100% under face mask oxygen. So she was then immediately sent to nearest hospital. And when upon arrival in ED, the GCS remained the same, which is 3/15. For blood pressure, 112/81, which is normotensive. Heart rate 102, which is slight tachycardic. SpO2 is 99% under nasal prong oxygen. Otherwise, respiratory, cardiovascular, and abdominal examinations were unremarkable. ECG shows sinus rhythm. She was then given IV normal saline for 100 cc, and the GCS subsequently improved to 10, and she was referred to pediatric team and was admitted to PICU. And then blood was taken for ABG, showing severe metabolic acidosis. Patient also appeared drowsy. She was therefore intubated and ventilated. She was given adequate hydration and IV sodium bicarb to treat the metabolic acidosis. However, despite fluid resusc, she developed hypotension, so noradrenaline infusion was started with maximum dose of 0.07 millikilogram per kg per minute. And she was then given sedation for cerebral protection. Blood investigations were all normal. However, there's acute kidney injury. CT shows no intracranial abnormality. And then subsequently, she showed rapid signs of recovery of metabolic acidosis and acute kidney injury. So on the third day of admission, she was extubated with all the blood parameters within normal ranges and no deterioration of condition. She was discharged well after 5 days of admission with PITS clinic follow-up 1 month later. So you might wondering how the species identification was done. So the parents was asked to bring the seed that the child ingested to the hospital. And they contacted National Poison Center for information and identification of the sample. So then the parents was asked to collect fresh samples with complete parts, which include the leaf, fruits, roots, and also flowers, if any, and send for analysis. And then subsequently, the species identification was confirmed and verified by School of Biological Science of USM and Forest Research Institute, Malaysia. Okay.
Yeah, very interesting. What is the name, common name of this Deris trifoliata? Do you know?
I'm not sure.
Local name? Do you have anything, Dr. Zuma? Dr. Prof. Also, Deris trifoliata.
Shrub. Shrub.
Yeah, it's a shrub. In Malaysia, we call it tuba. 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 I'm not sure why you call it in Cambodia or Thailand. But in Malaysia, this plant, usually the local people will collect the roots and also some of the trees, parts of the trees, even the sap of the tree, and they put it together. They shook into a container, like a water, and then they use it. They pour it in the pond or in the river, and then a few minutes later, the fish will come out. The fish will become intoxicated, and this is the way how they so-called catch fish by poisoning the fish. So this is called tuba or Deris trifoliata. Do you have the name of the active ingredients of the poison, Vera?
Sorry, Prof, what was the question?
Do you know? Do you have the scientific name of the chemical compound of this?
Oh, I don't have it, Prof.
So the chemical compound. Do you have? No, Leon?
Not sure, so Prof. I'm trying to search for it actually.
Okay.
Rotenone.
Yes, rotenone. Yeah, Dr. Sunghak. Yes, correct. It's rotenone. So, do you have a rotenone poisoning? Have you encountered before, Prof, in Thailand? I know there are a few case reports from Thailand about rotenone poisoning, but may not be from the same species of plant. But there are several others.
So I'm not familiar with this plant.
Yes.
So, I don't know about this, but I just wonder that what is the mechanism of poisoning in this patient? I mean, what kind of the toxin of this plant? Because
the toxin is called rotenone. Rotenone,
okay.
R-O-T-O-N.
Okay.
Rotanon, yeah. ROTONN. Yes.
Okay. I think that in our practice, many times that we will not start from the name of the plant or the toxin that they gave us. So we have
Yes.
approach from the clinical of the patient.
Yes.
So
Yes.
look like it's the clinical of the patient that
Yes.
have a suddenly collapse, they and unconscious. They might be from cardiovascular effects or central effects, right? But
Yes.
if you look at the vital signs of the patients in the 77 years old girls, and the blood pressure is 90/55 and the heart rate of about 87, this is quite normal. That's quite straight to me. That I expect that she might have some hypotensive or tachycardia than the vital sign that we have. But this is occurs. So, but in the next slide, please move to the next slide. Okay. She had the blood pressure is still better than in the first time, right? So this is quite difficult. It just only what they found that the patient have a severe lactic acidosis. Is that correct? In the first slide. Next slide, please. Okay, so she has a severe metabolic acidosis. And in my experience, what I found in this is a patient received something that might interfere with the what we call the respiratory aerobic respiration. They might interfere the Krebs cycle, electron transport, or something like that, such as cyanide, for example, that we found in the patient who took cassava.
Yes. That's
And
at the mitochondrial level, right?
right. And this might be rotinone, right? Also interfere the aerobic pathway somewhere. I'm not sure.
Yeah.
Yes, this may be the lactic acidosis may be markers that confirm us about what kind of the plant that the patient have to. Okay.
Okay. Dr. Sunghak, do you have any issue? Do you encounter local people using there is trifoliata for fishing in Cambodia? This is a traditional method of fishing actually.
I used to heard about it when I was in school, and
Okay.
but it's no longer it's no longer used right now. I believe the case of this type of poisoning was probably not diagnosed if even it is happened, because the truth is that we doesn't have the method to identify it. However, the only time that I was heard about the rotanon was the fishing thing. The leaf was put into the water to poison the fish, and the
Yeah,
fish
so
was
in
eatable.
Malaysia,
The fish was eatable.
Yes. Yeah. So people can also have used this for self-harm. Rather than use for the fish, they use for themselves. They try to commit suicide, so they drink this concoction of herbal remedy as well, of herbal preparation. So in traditional, besides also fish, they mixed it to the poison dart that they use for hunting. So they use it part of the ingredients also in that toxin to kill the animal that they go hunting using the blowpipe or arrowhead and so on. Yeah. Dr. Anissa, any input from you? Perhaps experience from the US Poison Center on rotanon poisoning, maybe? Or Malacca people don't use this for fishing.
No, I've not seen any rotanon while I was in the US, but
Okay.
what I can say is for us to diagnose the actual toxin is not easy,
Yeah,
especially when the patient comes in and you have no idea what is going
yeah,
on.
yeah.
So,
Undifferentiated patient, right? It's undifferentiated, right? So it's
so
purely symptomatic, right?
right, and the possibility is so wide. So
Yeah.
just don't panic, stay calm, and most of the poisoning we can treat by supportive.
Okay.
Yeah,
Yes. I think this case is treated with supportive care, I think. Is it correct, Vera? Yeah.
so you
So
may
Yes, Prof.
yeah, there's no specific antidote. That's one thing.
you may
Uh
or may not have an antidote, but
yeah.
you patients, even if you have antidote but you don't know what is the substance, you won't be able to decide what antidote to use.
Mm.
So most of the recovery is just good supportive management.
Yeah, and I think the good thing that we can comment here is that very good Vera showed a nice flow of how the risk trifoliata is being identified. So for us, we are not familiar with plants or things, so we need some expert. So luckily in Malaysia, we have a movement that trying to help a clinician to identify by engaging with plant expert in plant biology. For example, as one of the efforts being done by the National Poison Center, they may not be the expert in plants as well, but they have connection and communication with experts in the field for plants. And that's how, for us also, we have the Forest Research Institute, FRIM in Malaysia. So we help each other and we keep our communication open for such sudden consultation, for example, in this case. So I think the specimen was collected by the parents and then was sent to Pusat Racanegara or the biology center or something for identification. Forest Research Institute as well, I think. So yeah, so that's how we identify is there is trifoliata. It's not from the beginning the parents said, oh, my daughter or son has been poisoned by there is trifoliata. No, there's no such thing. We don't know what it is in the beginning, but this is like from the academic can actually help us identify the specimen. And we look at the sign and symptoms. It does match with the known effect of retinol, and there are several plants that produce retinol. It's not just this. There is trifoliata, so there are many other species of plant. But traditionally, it's been used as fish poison. But when we eat the fish, we do not get the poisoning. The fish got poisoning, but we do not get the poisoning by eating the fish. So that's very interesting as well. Okay. All right. So any questions regarding the risk trifoliata or retinol poisoning? In this case, it's accidental. It's accidental poisoning. The child, eat the fruit thinking is edible, and they eat it just one seed, just one fruit. The other friend also tried to eat it, but after eating in the mouth, he threw it out again. So he did not ingest it, but this child ingested the whole pot, the seed inside. The right one, okay? So she gets the sign and symptoms. So even just from one pot, okay, can cause such a dangerous sequelae, okay, or poisoning. Okay, any questions? Plant poisoning. We don't get these cases often. This is our first recorded case of there is trifoliata rotenone poisoning. Yeah. Any
Prof,
questions?
may I ask what is the workflow, or how do you guys work to identify
Yeah, Vera,
plant
can you show the
poisoning?
slide just now? Yeah.
No,
Yeah.
I mean in general. In general, was all the patient who is suspected to have a plant poisoning were asked to bring the plant and then go to the diagnosis center, like the flow, all of the case have?
Yeah, so
was the-
yeah, for this case, the poison center was contacted. So maybe Prof. Vinay would like to share your experience of managing plant poisoning in Ramati Bodhi.
Yeah, if they have, usually we collect the data to find out the clinical finding and the mechanism of the action that might be suggest as some kind of the plant. But the way to confirm is try to have the sample of the plant left over or the plant that they can bring
Fresh.
the plant the root, the fruit of that kind of the plant that the patient took to us, and we have a consultant, a specialist on the plant, the botanist, that can help us to identify. And when they identify the name of the plant to us, we have to match with the clinical that we can find from the literature. That will be make us can make the diagnosis. So in the past for the rotenone in Thailand, we do have experience that most of the patient they took the root of some kind of plant. They cannot recall the name of that plant, and they use in the past they use for cute fish, right? That's correct.
Yeah, but that case was I think trying to self-harm, right? That case was drinking the root just for self-harm, for committing suicide.
Sometimes it is accidental to as well.
Accidental also. Okay. All right. Yeah, but for this child, it's the fruit. We never heard anyone got poisoning from the fruit, but apparently this is the one of the maybe a reference case that the whole plant is actually can be dangerous, not just the root of the plant that is used for fish poisoning. Yeah, maybe the leaves as well. Yeah. Okay. All right. Is that okay, Dr. Ng? Your question?
Yes, thank you.
Yeah. All right. Okay. So, any other questions from the floor, moderators?
As of now, we don't have any question in the chat box. So maybe we can move on to the last case for today. Okay, for the last case, it is a case of a 39-year-old female with no known medical illness presented to ED with abdominal pain, body weakness, vomiting, and palpitations 2 hours after ingestion of horseshoe crab. She had a history of ingesting cooked horseshoe crab at 1:30. 2 hours later, at 3:30, she started to develop diaphoresis, palpitation, intermittent abdominal pain, colicky in nature, vomiting 4 episodes with minimal amount and undigested food content, persistent tongue numbness, and body weakness. So, further history taken from the patient, she actually brought the crab from market in Cebu, which cost 7 ringgit per pair. So she processed and cooked the crab after learning it from YouTube. She then fried and cooked the crab with the egg and chicken. And then she consumed it together with the raw and the meat alone, and other family members refused to eat it. Then she discarded the leftover cooked crab after she had developed all those symptoms mentioned just now. And she actually had history of consuming horseshoe crab at 8 years old with family, but there was no adverse event occurred at that moment. So upon arrival in ED, she was alert and conscious, GCS full, pupil reactive, warm peripheries, good pulse volume, CRT less than 2 seconds, and no ptosis. BP was 134/88, which is normotensive. Heart rate 80, normal. SpO2, 99% under room A. Otherwise, respiratory, cardiovascular, and abdominal examinations were unremarkable. So patient discarded all the leftover horseshoe, therefore unable to send sample for further testing. The horseshoe crab is confirmed by patient after she showed picture from the internet. So the diagnosis then was grade 1 tetrodotoxin poisoning from consuming horseshoe crab. So subsequently, she was discharged well, hemodynamically stable, and vital sign also stable. All symptoms were resolved, and the blood parameters was within normal range.
Okay, very interesting. Dr. Anissa, maybe you can start the ball rolling about horseshoe crab poisoning, because I know personally we have a lot of horseshoe crabs in Malacca. And I personally have eaten horseshoe crab in Malacca as well. So, Dr. Anissa, Portuguese Square, there's a Portuguese Square, they sell horseshoe crab barbecue.
Oh gosh. Well, I think the toxin from this horseshoe crabs, tetrodotoxin, which is a neurotoxin. Yes, you are right, Carl. There are some places here in Malacca that sell this horseshoe crab. But I've I've not had any cases of poisoning so far in Malacca.
Have you eaten one before?
No.
No.
And I will never eat it.
Okay. Prof. Vinay, we know that Thailand has cases, mass poisoning from horseshoe crab poisoning, south of Thailand. Yes.
Yes, we do have a case of tetrodotoxin. So I would like to point you in some the clinical. If you found the patient eat some things and followed by the neurological abnormalities, especially you have the patient have a numbness of the tongue or perioral hand and the feet, and after that they develop the muscle weakness. This is a classic features of the tetrodotoxin. And the other toxin that might cause the same clinical presentation is the toxin that from the snail. That is
Yeah.
sorry.
Pufferfish as well, isn't it? Fugu.
The pufferfish, yeah, that is the pufferfish, right?
Yeah.
And also the sexy toxin from the snail also cause the onset of the toxin is quite very rapid.
Yes.
Usually the patient have the symptom start from nausea, vomiting, abdominal pain within minutes to hours after they took that kind of the food that contain the toxin.
Okay. So
And because the toxin is like so many of the history that they eat the cooked food, the already cooked food. So it is not the quite of the food poisoning from the bacteria. That is not the not well cooked food. That is a kind of the differential diagnosis for that for this. Okay, and for the history, they say that in the past they took this kind of the horseshoe crab and never they did not develop any illness because the toxin is produced by the we believe that by the bacteria or micro phenolates from the sea, and these animals that can uptake the toxin into the bodies, especially the eggs and the visceral. In the pufferfish, it is also in the visceral organ as well. So, and we found that they have a seasonal variation. In some period, the toxin is very low. So the patient took the horseshoe crab. They said, "Oh, it is very just delicious, nothing."
yes.
But it's sometimes when they took the horseshoe crab, it might be deadly. And in this region, instead of tetrodotoxin for the horseshoe crab will start about in December to February. That is the time that the horseshoe crab will have a high content of tetrodotoxin. The other period, the content of the toxin in the horseshoe crab is smaller. So if the patient took at that time, they might have any toxicity. But this time it will be the very high risk period for eat the horseshoe crab.
Yeah.
That is our static. We know from our poison center statistic. Thank you.
Is it for all the species of horseshoe crab, or is there a particular species of horseshoe crab? There are several species. There are not many. I think there are about four species that we have in this region, and they said the way that we tell whether it's higher risk of poisoning is looking at the tail of the the spine. If it is triangle or is it round. You want to comment on that?
Right. Yeah, they have two types of the horseshoe crab. One is bigger, and their tail, when you cut the surface, maybe it's like a triangle. The name they follow by something like a jinga or something, jinkan. And for that one that contains the high toxin will be the rotundum. That means that the tail is the cutting surface is a round.
Yes.
That is the high toxic. However, we found that not common, but we found that some patients they have a history that they eat the one that eatable, but they still have poisoning. That we I'm not sure that is it because it is a wrongly identification, or some of these eatable also contain the tetrodotoxin that have not proved yet. But I will suggest that if you like to eat, not eat eat the period that they have a high toxin.
Yeah, I did eat one when I visited Bangkok in Thailand. So I survived. Yeah, it was it was okay. Yeah, I grew up in the village, so in Malacca. So we had seasons where there are a lot of horseshoe crab come up for mating and also laying eggs, and that's the time where people catch it because they eat the flesh is not much. There's nothing much to eat with the flesh, but eat the roe, the eggs. So the eggs is in the carapace, so you don't see it, but you have to break the shell, and then only you can see the eggs. So that's what we ate, what we cook, and there's the local people know about the poison that it contains. So they said the way how you clean or remove the parts, especially the gut of the under part here, there's the gut that has to be removed intact, should not be broken. So if it's broken, then the poison will contaminate the eggs and so on. So that's the local knowledge, and they can't explain what is the poison, but that's how they've been practicing, and they say that's how it's supposed to be prepared, to be carefully cleaned and removed, so that it will not contaminate with the poison. So they know it's poisonous. Perhaps they had already past experience of people having poisoning, but some who are preparing well, like the chef in Japan for fugu, they know which part needs to be cleaned, so the flesh that they serve is safe. So similarly with this, perhaps, but but don't learn from YouTube like this lady. She learned how to prepare it from YouTube, so it shows that it's not correct as well. Yeah. So anyway, it's very interesting. The good thing about how horseshoe crab is a prehistoric animal. It has been around for millions and millions of years, and it is very unique that it has a blue-colored blood, and the blue-colored blood is actually utilized pharmacologically in the preparation of drugs in the pharmacological industry. So they are harvested for their blood actually. Interesting. You can see the documentary about horseshoe crab. Okay, so yeah, they are very strange looking creatures. They are very interesting looking. I have always been fascinated by them since I was small. I was, whenever I go to the beach, I will look for them in Malacca. So we can catch them and play with them. Yeah, the male is very small, smaller than the female, and the male will hold on to the female on the back. They will clip their and attach to the female, and the female will carry the male on top of them everywhere. So that's very interesting to see as well. Okay, anyway, that's biology, but we're talking about poisoning. So those of you who has not eaten this horseshoe crab, you should try and see if you survive or not after that. Yeah, okay, you can go to Thailand for it. It's a delicacy in south of Thailand. Yeah. Well, Dr. Ying, sorry, we missed you. Do you have horseshoe crab in Cambodia?
No, it's okay. It's okay. Because I don't believe that we have horseshoe crab in Cambodia. I have never saw it in
Is
my life.
Does Cambodia has a sea?
Yeah, we do. We do.
Oh,
We
you
do
do?
have crab.
Sorry. Okay. I thought Cambodia is
But
all in there.
yeah,
Oh,
horseshoe
that's
crab is
Laos.
not
That's
available.
Laos. Laos doesn't have a sea. Yeah. Okay. So do you have horseshoe crab in Laos? In Cambodia? Sorry.
No, I don't think so. Perhaps the fishermen would probably catch some of them. However, they would not eat it. We don't have the habit to eat it, and it is not available on the market right now. I don't believe it
Okay.
will be available anytime soon.
Okay. So treatment is supportive, right, Prof?
Yes, just supportive. Usually the patient die from respiratory failure.
Yeah, you
So
said right?
the
Dr.
most
Lisa was-
important thing is to respiratory support, intubation, and ventilation support, and mostly the patient will recover within 2 or 3 days. That's all.
Yeah.
If we can save their life, they absolutely completely recover. No any residue.
Yeah, I agree. Okay, any last words? Any questions anywhere? Anybody has any question? Anissa, you want to say anything?
No, Khaldun. I don't think so. Just a quick one. Does the students know the horseshoe crab's blood is blue?
Yeah, I just mentioned just now.
You did? Okay. Just out of interest. Come to
Yes.
Malacca and see the horseshoe crabs.
Yeah. I sent a video live, horseshoe crab, to the students already in the file. Yeah. Okay, so back to our moderators.
Okay, so as of now, we don't have any question in the chat box. So thank you to all prof and doctors for the insightful sharing. For a record, I also eaten one before and luckily I'm survived. Okay, so now
Where? In Sabah, right?
Yes, in Sabah.
Sorry, did you eat it in Sabah? In Sabah?
Yes.
Sabah, yeah.
Okay. Now I think we can move on to our Kahoot session.
So for the Kahoot session, we have prepared a quiz with a special prize for the winner. Please scan the QR code or key in the pin in Kahoot to play. At the end of the quiz, we will display the QR code and link for eCert, so stay tuned. Third place, we have Pan KL. Third place, we have 163.085. First place goes to... Wow, congratulations. Can we have a look at your... can you on your camera? Congratulations and well done everyone for your effort. To the winner, please reach out to any of our secretaries. I would like to pass the floor back to Vera.